Darryl, thanks very much. There's one inaccuracy, I think, in the program. I don't work at the CEC and I'm retired, and you know when your career's over when you're invited to give a talk about the history of medicine. I don't know whether it was mentioned yesterday that this meeting is now 10 years old, and it was originally Graham Hart's idea. He wanted to have a winter meeting in contrast to the Noosa meeting, and the first couple of meetings were held in Queenstown in the snow, and that idea lost its gloss when there were a few injuries and the staff had to go back and report to their employers why they had broken legs. I'd also like to recognise Jenny Holmes, who put so much work into the Safety and Quality Committee. What I'm going to talk about today is the CLABSI program and how it evolved, with a little bit of reference to the sepsis program. So, 1995, Ross Wilson publishes his Safety and Healthcare paper, which created a furore. And following on from that, there was the Bristol Infirmary disaster. And at this stage, the New South Wales government became a little anxious, and they produced a framework for safety and quality in healthcare. And that framework involved, amongst other things, the setting up of clinical governance structures in each of the area health services, a director of clinical governance, patient safety manager, and so on. And at the Department of Health, they set up what they call the Quality and Safety Branch, henceforth known as the QSB. Now, by 2004, 2005, the QSB were working with a group of infection control practitioners, and they wanted to set up a surveillance program looking at multi-resistant organisms, healthcare-associated infections, and so on. And what they did, as all bureaucratic organisations do, they built this into the Chief Executive's performance agreement, sent a letter to the Chief Executives of the Area Health Service saying, you will reduce the CLABSI rate by 20% in the next couple of years, and by, I think, 80% by 2010. Now, my friend Michael Smith, who deserves a mention in this, was at that stage, for reasons known only to himself, the director of the Quality and Safety Branch. And around Christmas 2006, he read Peter Pronovost's paper on the Michigan CLABSI, the work they'd done in Michigan. And he looked at what was proposed in New South Wales and he said, well, where's the clinicians? Because obviously this was a classic top-down bureaucratic policy directive to the Chief Executive. So what the CLABSI program, as it was called, then became a top-down, bottom-up. And it was modelled on the Michigan study, hand-washing, full barrier precautions, cleaning the skin and so on. What we sold it was, we tried to keep it really simple, we sold it as just do it as you would in the operating theatre. It was set up using the IHI breakthrough methodology, steering committee, expert groups and so on. The evidence was for the intervention was talked about, learning lessons and hopefully creating goodwill in the room amongst the clinicians. One of the issues, or one of the things that became an issue, was the lack of understanding of the standard definition of a CLAB. Now the team was situated at the CEC. You've heard Malcolm's talked about the CEC a fair bit, but I would also like to acknowledge Margie Murgo and Ida Calabria, because without them this wouldn't have happened. The intervention, aseptic insertion, as in the operating theatre, there was a checklist, and they divided checklists into the clinician bundle, which was really gown, glove, mask and hat, and the patient bundle, chlorhexidine prep, fully drape the patient and check the position of the line. Malcolm, I have to say that at that stage anyway, nobody liked the concept of a bundle because it was some imported American idea. The most important thing was they engaged with anybody who was interested, anybody at all, nurses, cleaners, anybody who had passion and would drive it, bring energy to it within their department. Teleconferences, site visits, monthly data reports, communicating by email. And the other thing that we really set out to do was to write this up and make the contribution to the literature, not in some sort of obscure quality journal which only quality people read, but mainstream clinical journal. This is just an example of the checklist. The clinicians were to fill in, or did fill in, surprisingly often, the checklist and then fax it to the CEC. This were the days of faxes. And using teleform technology, it would take the data off that fact sheet and make a database for us. It was extraordinarily clunky, so Margie and Eda spent hours and hours late into the night cleaning the data, checking it, checking the quality, producing the monthly reports, which were then sent back to the various ICUs participating. And one of the things they found, just to restate, a poor understanding of the definition of CLAB. Now, this data collection was absolutely laborious and influenced what we did in the sepsis program. There were some really interesting organisational issues. First of all, this depended on goodwill. The system had experienced trying to do programs and putting project officers in hospitals before, and it had no or very little success. So basically the team at the CEC and some funds for support, and that was it. So it was very important, that goodwill that was engendered. The ICU leadership was really very interesting. Some directors were supportive, some directors were not supportive. Some just let it happen. Often the responsibility was delegated to somebody who was interested or somebody who wasn't interested. And what was really apparent to us was that the impact of the leadership within that ICU was readily visible. And overall, the project illustrated the lack of quality improvement processes and proper audit within ICUs at the time. Remember, we're talking about 2008 now. It's a long time ago. What was also really interesting was the culture that we were trying to get this to happen in. The reporting requirements were seen as an imposition. Where's the money? I'm not going to do this if you're not going to give me the money. It's just another bit of data that I have to collect that's going to go nowhere. Or the other one that I like is apathy. We don't have CLABS in our ICU. I mean, I know they do at North Shore, but not. So we got quite a bit of that. And the other one was, we have more important problems to deal with, don't worry about this. And then there was the I don't believe the evidence, which I translated as I don't want to do it. And it was a mistake promoting Pronavost's work as the prime paper. There's an awful lot of evidence around what we were trying to sell, but we put too much emphasis on Pronavost. So there were a subgroup of individuals who got into that paper and really picked it apart and looked for all sorts of reasons why it didn't work. And there were these preconceived value judgments, excuse for not changing, and 4 ICUs, very interestingly, absolutely refused to wear hats. Now, you'd be surprised the arguments we got. Well, look, I'm not going to wear a hat because that's going to wreck my budget. Well, $3 for 100 hats. We priced that out. We did some work looking at why you would wear a hat. There's more staph in your hair than there is in your armpit, but nothing worked. And why fully drape the patient? What's wrong with using a circ towel? So there was all sorts of resistance. We've written this up, so I'm not going to spend too much time on it, but over the 18 months, the CLABSI rate reduced to less than 2 per 1,000 line days. And looking at the data in the checklist, if people wore hat, gown, gloves, mask and so on, there was a reduction for CLABSI in the central line, and if they did everything, then the relative risk of a CLAB was 0.6. So that's really very good, very successful, very happy that we demonstrated that doing it as in the operating theatre worked, and hopefully we changed practice. But probably what's more important for this group is the subsequent analysis that Mary Lou McLaws did, and she did a survival analysis of all the central lines, looking at how old the line was when the affection occurred. And she demonstrated a couple of things. One is that in tertiary ICUs, the effective life of a central line, the lowest probability extended from day 7 to day 9, and that 75% of central lines stayed less than 7 days. And if you looked at that group of patients, the CLABSI rate was less than 1 per 1,000 line days. So jumping forward to the ANZICS, the national program, that's where the benchmark of 1 per 1,000 line days came from. So re-enter Michael Smith, who had escaped, if you like, from New South Wales Health and was now working as a senior medical advisor at the Australian Commission. But he was still very enthusiastic about this, working with clinicians, but he sort of had the bigger picture. Now he wanted the Australian Commission to work with the colleges or with ANZICS or whoever could effect some change. So he proposed that ANZICS, the Australian Commission, get together and set up a national database for CLABSIs. And they funded, I see Gabrielle Hanlon down here somewhere, who sat at ANZICS House and wrote the first guideline, and that's subsequently been followed up by an implementation guide for surveillance, and surveillance of CLABSI has been built into the Australian national health standards. We had a great time travelling around everywhere, launching the national program. The beauty about ANZICS doing this, of course, there was CORE. CORE was used to collecting data, and it was used to, people were used to submitting data, people were used to looking at data online. So they were comfortable with the process. So does it work? Well, the number of ICUs reporting remained consistent over time. The CLABSI rate well below 1 per 1,000 line days, and maybe it's time that was reconsidered. The health service managers take the Australian Commission standards very seriously. That's what drives chief executives, so you're getting support, or should get support, from hospital, and we have to call them local health districts now, rather than area health services. CLABSI is on the infection control agendas. Much of this data is actually collected by infection control practitioners who keep an eye on what's going on and submit it to their jurisdictional officers. CLABSI is on the ICU clinicians' agenda. Everybody wants to know what's going on. We were certainly aware that when we were doing the program, that a couple of directors found out their CLABSI rate was 3 times higher than anybody else, and they were energised by that. Yes, but that's all very well. But what was happening at the coalface? Were people still putting in central lines as you would in the operating theatre? And the numbers look good, but were they actually doing? Had we changed practice? I just want to digress a little bit to the sepsis program, which you've heard quite a bit about. And this very quick summary here: documented incidents, failure to recognise sepsis. We put emphasis on Kumar's paper, and Kumar said that after the onset of hypotension, every hour you delay the antibiotics, you've got an 8% increase in mortality. What was really interesting here is everybody accepted that. I was expecting lots of argument about, well, you know, you're talking about all sepsis, not just people who are hypotensive. Antibiotics may not be needed to give them. None of that. It was everybody accepted it. We started in all the New South Wales emergency departments, of which there are an awful lot. We promoted the triage tool that you've already seen, the three-word mantra: recognise, resuscitate and refer, long before Tony Abbott. We used the same methodology, and this is, I think, the point that I want to get across today. The team at the CEC, Simon's gone, but yes, we were under-resourced, but they developed a horizontal network with the clinicians, emergency clinicians, using the clinical governance staff. Again, they looked at the data, they reviewed the data, did everything they could to talk to individuals in all the participating emergency departments. It's 180 odd emergency departments in New South Wales. We got data, I think, from 84, but a lot of the others actually used the program, just didn't submit the data. The data submission was voluntary. Nobody was paid for this, as far as I know. It was because everybody was engaged, wanted to be part of it. When we wrote the paper up, we looked at 13,567 records. So these records were submitted by the staff in the emergency department. They were submitted online. We'd moved beyond the teleform. We'd set up an online database. They entered the data, and that allowed them to look at what was happening in real time. Now this is a bit busy, but if you see the blue line, I think will this work? Yeah, the blue line, that's the state average, time to antibiotics. If you look at the yellow line, that's the intensive care units within that particular local health district. And if you look at the red line, that's actually the emergency department in one of Sydney's premier teaching hospitals. So they allowed themselves to look at that, to look at what was going on. And Malcolm's already shown you this slide, but it's not the slide, thank you, not the slide I want to really emphasise. What I want to emphasise, at the 30th of June this year, people had continued to submit records into that database of 41,000. That's just voluntary. That's a database, 41,000. Pretty exciting, I think. Now, while we were sort of drawing our program to a close, the NHS were working with Julian Bion, and they were doing it in 230 odd English intensive care units. And this important paper, which has been cited 400 times or more, from Mary Dixon Woods, it's an ethnographic study of how the Michigan study worked. And they looked at what were the factors that made a program work. And there's some interesting language in here which I don't understand, like isomorphic pressures. But this is the one that I really like: densely networking community with strong horizontal links that exerted normative pressures on their members. And reframing CLABSI as a social problem involving human behaviour, which is what we certainly saw in our program. And so on and so on. Can I commend the paper to you? It's well worth reading, particularly if you're starting a program. So, when we're doing this, we need to have a look. We really need to think about what's in it for the clinicians. You need to make the case, not just intellectual, but emotional. What grabs them? I didn't spend any time talking about the logo. In the CEC, the Chief Executive, Cliff Hughes, was really seriously into logos, and I always thought it was a bit of a wank. But the time bomb with the hour in it, you have no idea where that turned up. And for World Sepsis Day, they made time bomb cakes, and I saw it appear on international programs. Importantly, what happens when no one's looking? What happens at 10 o'clock at night when you just happen to walk through the unit and there's the registrar with a pair of gloves putting in a central line? So you've got to be able to make this intervention habit and routine. It is essential to foster a network community of practice. That's where the energy of change for change comes from. We used social media. We used Twitter. Unashamedly used Twitter, and allowed us to make all sorts of friends, not just locally, but actually internationally, particularly with the Scottish network who were doing some work on sepsis. Facebook, there are all these tools available to support staff. There's even me on YouTube. You need to make a clear sense of progress, visible progress, meaningful feedback. Have to measure something. This is well written up in The Power of Small Wins in the Business Harvard Review. It's worth, again, Googling that. But that's what measuring it's about. That was about real time looking at what's going on. And you need to have persistence. You need to keep going until it's not just the early adopters, but it's that vast number in the middle. Forget about the late adopters. They'll come in the end. Now this picture, this is actually, I don't know whether you can see it, But there's our logo, and this is Aberdeen in Scotland. So can't underestimate the emotional impact of a time bomb and other marketing. Thank you very much.